There, okay. Good morning, buenos días. Hola, muy bienvenido a la OPS de Washington. Good morning, everyone.
Good morning, everyone. Welcome
Here
to
in the
PAHO, Washington,
headquarter
D.C.
offices in Washington, D.C., and who's connected online. We're just gonna wait one more minute to begin the program. And in the meantime, if I could ask everybody who's here in the room to please take their seats. And also, I would like to invite to the head table our first set of presenters, Dr. Bianca Hemmingson, Dr. David Barron, Dr. Goika Roglic, who's connected online. I hope you're connected. You're in the first session. And Dr. Anselm Hannes and Dr. Carmen Antini. Welcome to the front table, to the head table. And let's just wait one more minute as people connect to the Zoom. And while we're waiting, I'd like to say that the meeting is going to be in English, Spanish, and Portuguese, and we have simultaneous translation. So thank you to the translators for making this language accessible for many. And for those connected on Zoom, you can select the language of your choice. And for those here in the room, please use the headsets that are available at your table and to connect them to the computer that's in front of you. So welcome again to the Pan American Health Organization in Washington, D.C., and to those connected on Zoom. I'm Silvana Luciani from the Non-Communicable Disease Program at PAHO, and I'll be moderating today's meeting, which is on improving diabetes care and research. And we're thrilled to have so many of you here in person from our regional offices of WHO and headquarters of WHO, our partners, from our member states, from programs across PAHO to talk about how we can improve diabetes care and what the research priorities are. And we have a really exciting program for you today because we're going to launch the new Global Diabetes Research Agenda. And you know, we've organized this meeting to be a global, but also a regional focus event to talk about the growing burden of diabetes. And we're doing this on the heels of World Diabetes Day, which was just last week, where we saw some very alarming new data on diabetes prevalence. About 800 million people are living with diabetes now. That's a fourfold increase in the past 30 years. But more worrisome is that more than half of those people do not have access to treatment. So we have big problems to address over the next 2 days in this meeting. And you're going to learn on how can we address these problems through implementation as well as through implementation research. So again, we have an exciting program of presentations as well as dynamic panel discussions. And to kickstart us off, I'd like to welcome the Department Director of the Pan American Health Organization for the Program on Non-Communicable Diseases and Mental Health, Dr. Anselm Hannes, to provide some opening remarks. Dr. Hannes.
Yes, good morning, all dear colleagues. Gives me great pleasure to welcome you to our regional headquarters in Washington on this overcast fall morning. And we're going to be discussing improving diabetes care and research priorities in commemoration of World Diabetes Day. I wish to thank colleagues from WHO headquarters and regional offices for their collaboration. And I wish to express my profound gratitude to David Barron and the University of Geneva for the leadership in diabetes research and for co-sponsoring this event with the Pan American Health Organization and the World Health Organization. As we all know, diabetes is a significant and complex public health challenge. The prevalence, mortality, and disability caused by diabetes have all risen notably in recent decades, especially in low and middle income countries. Between 2000 and 2019, diabetes was the only non-communicable disease that exhibited an increase in premature mortality globally. Unless appropriate interventions are implemented, the burden of diabetes is projected to continue growing. These interventions encompass ensuring that individuals with the disease can access quality healthcare and receive social support for effective management, preventing complications and premature death. In the region of the Americas, NCDs are the leading cause of death, with 1/3 occurring prematurely. That's between ages 30 and 70. Millions of people live with diabetes and need ongoing access to treatment and care. The recent global estimates show that in the Americas, 112 million adults, which is 13% of the adult population, are living with diabetes. And this is 4 times the number of persons affected in 1990, which is 30 million adults, or then 7% of the adult population. In the Caribbean, the prevalence is even higher, between 20% of the adult population. Ensuring access to treatment continues to be a challenge in the region, with an estimated 43 million people with diabetes unable to access appropriate and adequate treatment, highlighting the urgent need to expand access to primary healthcare services. Through the POWER Initiative, Medicare for NCDs, and I'm sure you're going to hear a lot more about that in the next 2 days, we are aiming to reduce this gap in treatment and care. More research on diabetes prevention and care is needed, especially on how to better adapt policies and innovate practice. And we are really thrilled today that the new WHO prioritized diabetes research agenda, developed in collaboration with the University of Geneva and the University of Sydney, will be launched. Thank you for your attention, for your participation, and your commitment. And I look forward to the discussions that we'll have over the next 2 days on how best to improve care for people with diabetes and how to implement the research agenda. So good morning yet again, and welcome one and all. Thank you.
Thank you. Thank you very much, Dr. Hennis, for those very warm, welcoming remarks and for setting the scene for our first panel. And on this first panel, we'll hear a little bit more about what is the global situation for diabetes, what is the WHO doing through the Global Diabetes Compact, and you'll also hear about the new and exciting diabetes implementation research agenda. And this will be complemented with what we in the region of the Americas are doing to address the growing burden of diabetes in the region, and what regional initiatives like the Better Care for NCD initiative are available to the member states in the Americas region. So in this first panel, I'd like to introduce them, and then we'll have the presentations in order. So first we have Dr. Carmen Antini, the Regional Advisor for Diabetes Program here at the Pan American Health Organization. We have next to her Dr. Bianca Hemmingsen, who is the Global Lead for Diabetes Program at the World Health Organization. And next to her is Dr. David Benning, a lead researcher in diabetes at the University of Geneva and also a member of the WHO Technical Advisory Group on Diabetes. So a warm welcome to our panelists. And I'd like us to first get started with our global overview of diabetes and welcome Dr. Hemmingsen to give a presentation on the Global Diabetes Compact and global perspectives for diabetes care.
Yeah, thanks a lot for the introduction. Thanks a lot for all of you for joining here today. I will start with a presentation about the Global Diabetes Compact to show some of the work that we're doing at global level. Yeah, due to the increasing burden of diabetes, it was already acknowledged back in 2021 that the burden was increasing, and therefore member states endorsed a resolution with the title Reducing the Burden of Non-Communicable Diseases through Strengthening Prevention and Control of Diabetes. This resolution was endorsed by member states and places demands or asks to the member states of what they should do to commit to the diabetes burden, but also list a request to the DG. I will not go through all of them, but here I've just listed 4 of the 8 out of the 8 requests that that is for the DG, or it means then the World Health Organization to fulfill. But one of them that is very central is the development of targets, also pathways to achieve the targets, and also strengthening policies of diabetes prevention and control, and also help with surveillance and monitoring and access to medicine. The endorsement of the resolution was very timely because earlier the very same year in 2021, we had launched the Global Diabetes Compact. And again, it was with a huge interest from several member states and also from the PAHO region. And we actually had 15 speakers from the PAHO region supporting this event. And it was hosted together with the government of Canada. The objective of the Global Diabetes Compact is listed here. It is to reduce the risk of diabetes and to ensure that all people who are diagnosed with diabetes have access to equitable, comprehensive, affordable, and quality management. In order to achieve the objective of the Global Diabetes Compact, as well as achieve the global coverage targets, we have developed 6 work streams. They should not be seen in silos, but they all interact with each other. Work stream 1 is access to essential diabetes medicine and associated health technologies. The second one is technical product. The third is prevention, health promotion, and health literacy. We have country support, research and innovation, and finally governance. I will not go into all of them in detail, but just show some examples of initiatives that we currently are working on. For the work stream 1, access to essential medicine and associated health technology, one very crucial part of this work is the dialogue with the private sector. And we have had private sector dialogues the last couple of years, and we have another one next month. One of the asks was pre-qualification, and we have had pre-qualification of human insulin and insulin glargine. And currently, we are working on pre-qualification of blood glucose meters and HbA1c point of care tests. Other things that we are working on is the development of an NCD medicine forecasting and quantification tool, which should support member states in estimating their demands. One of the most important technical products that we recently have developed is the global coverage targets for diabetes, and they were endorsed by member states in 2022. It says that 80% of people with diabetes are diagnosed, 80% of people with diagnosed diabetes have good control of glycemia, 80% of people with diagnosed diabetes have good control of blood pressure, 60% of people with diabetes 40 years or older receive statins, and 100% of people with type 1 diabetes have access to affordable insulin treatment and blood glucose monitoring. These standards are to be set by 2030. They are ambitious, but they should be achievable. We have already now several technical products, and I know several of you here in this room and likely also online, you already know some of them. For example, the HEARTS package and the PEN package that we have to support primary healthcare. But we are working on additional technical products in order to support the achievement of the targets. So one thing to acknowledge is that diabetes it impacts life through the life course. So we have technical products already starting from pregnancy. We're also working on type 1 diabetes guidelines in children, and also management of diabetes in adults, both type 1 and type 2 diabetes. Again, surveillance and monitoring is strengthened, and we recently launched the global monitoring framework on how to monitor the global targets. And then we are working on the cross-cutting comorbidities as diabetes influences several conditions, therein tuberculosis and oral health. The third one, prevention, health promotion, and health literacy. Again, PAHO are very good and have shown a lot of commitments. 9 front-runner countries in this region have executed the plan. We also worked on tobacco knowledge summary on diabetes, as tobacco is a risk factor for type 2 diabetes, and we have a lot of ongoing collaboration to further help prevention of diabetes. Country support, it's really core for us to have a strong country support, as this is where we see the effect of the different initiatives. We have regional adaptations of the Global Diabetes Compact. And again, PAHO was actually the very first region to make a global adaptation, or make a regional adaptation of the Global Compact. We help with adapt HEARTS into country context, and we also provide technical support for meetings and also support grant proposals, both as regional and national levels. Here's just some examples for the last few months that we have been working on. We were in a workshop last month where we supported the integration of diabetes into TB and HIV programs. And we have been piloting a therapeutic patient education module on diabetes in the Eastern Mediterranean region. And I know Komarini, he will later be a panelist, but we have, together with our Afro colleagues, worked a lot on making a regional framework for the implementation of the Global Diabetes Compact in the Afro region. For the research and innovation workstream, we have this launched today. Thanks a lot to David Baran and Goika Roglic and Emma Cox who are here and all the experts who have contributed, but we'll hear more about this later. And in addition, due to the increase to AI, artificial intelligence use in the retinopathy field, we are currently looking into standards on how to use those tools. This is my final slide, and it's just to show the engagement structure we have in the Global Diabetes Compact. As you see, it's very broad, and we need all hands on deck. Of course, we have engagement with the regions and member states, which is very core. We have our technical advisory group of experts on diabetes, and we have 2 representatives from each region, so also 2 here from the PAHO region. We have the Global Diabetes Compact Forum, which convenes stakeholders, and then we have the People Living with Diabetes consultation, which takes place annually, where we get inputs from people who are living with diabetes on different aspects of our program and how they can support. And then finally, as mentioned initially, we have the engagement of the private sector to increase access to medicine and associated health technologies. So this was all from me from now, but thanks a lot.
Excellent. Thank you very much, Bianca. Thank you. Thank you for providing us that overview of the Global Diabetes Compact, which really is the global commitment around how can we halt the rise of diabetes and how can we improve care and treatment, as well as improve monitoring and surveillance of diabetes. And there are some excellent tools that Bianca has shown you very rapidly, but I encourage everyone to visit the WHO webpage on the Global Diabetes Compact, where you can access the many tools like the guidelines, the monitoring framework, and also perhaps get engaged if you're not already engaged as part of the global engagement for the Diabetes Compact. So thank you again, Dr. Bianca Hemmingsen from WHO. So we're going to continue now to the region of the Americas, and I'd like to invite Dr. Carmen Antini, who's going to talk about the regional approach to improving diabetes care in the context of PAHO's initiative on better care for NCDs. Carmen. Y la presentación será en español.
En español.
Así que si ustedes necesitan traducción.
I will be speaking Spanish.
Pero antes de iniciar la
So
presentación,
before I start my presentation,
ya los he-
I
he
wanted
dado la bienvenida
to,
cuando estaban entrando a la
well,
sala, pero
actually, I welcomed you when you were walking into the room.
agradecimiento
But
porque
I do want to express my appreciation. Most of you have come from far away, especially now at year end when everybody is very busy. Everybody is trying to wrap up activities, putting finishing touches on reports. So I'm really glad that you found time to be here today. And here I'm referring to those here in the room and those that are connected remotely. We have colleagues from Jamaica, Cuba, Argentina, Mexico, Paraguay. So we have a lot of questions, a lot of people attending, and I appreciate that. What I'm going to be showing you today is something having to do with why should we be concerned with diabetes? I think we all know the answer, but it's good to review. So who are we talking about? Who are we talking about when we call this an epidemic? So who is dealing with this burden of disease? As Silvana said, as Dr. Hennes said, the prevalence of diabetes has gone up. It has really exploded over the last few decades. You can see on the screen the number of people in 1990 was 30 million. And in 2022, the estimate is 112 million. So we can see that there has been 100% difference between the two figures. So as key points having to do with an increase in prevalence of diabetes, and I mentioned that right now we have 112 million people with the disease, but let's remember that the 112 million are those who know that they have diabetes. Unfortunately, we have a high percentage of people who, even though they do have the disease, they don't know that. And since they don't know that they have diabetes, they don't seek treatment. If we focus on the subgroup of people that are 30 years of age or older, we have a fact that is worrisome, and that is that treatment is only available to 57%, whereas the number of people receiving treatment or that should receive treatment are the 62 million. And right now, we have 43 million people that are 30 years of age or older who are not receiving treatment. That means that 43 million people. And here, I'm going to make what I'm saying personal. Amongst those 43 million people that currently are not receiving treatment, we're probably including a colleague, a friend, a member of our families, someone that is dear to our hearts. But when we talk about the people not receiving treatment, we are talking about all of us, because this is something that affects. Now, let's look at mortality. With mortality, we see something similar. There have been points over the last few decades, and here you can see information from 2000 to 2021. And you can see the increase in diabetes during the COVID pandemic, and that is the spike that happened in 2020. Then there's a slight decrease in 2021, but the truth is the levels are high. And here, note the relative difference between the 2 years. It is greater in the case of males when compared to females. Now, if we focus on a disability associated with diabetes, the outlook is worrisome. There is a definite upward and consistent trend, and that affects both genders. And not only is this the case of disability, but also premature death because of diabetes. And again, premature death affects males more than females, and you can see the impact of the COVID pandemic on the increase in these numbers.
Si nosotros quisiéramos tener una aproximación a qué también estamos haciendo las cosas.
If we were to try to assess how well we are doing in dealing with diabetes, we could focus on chronic renal disease caused by diabetes. That is one of the main complications of this disease. And in that case, what we find is something that is equally worrisome. The difference in mortality rates because of chronic renal disease in persons suffering from this disease and that also have diabetes is 57.2% in males and 34.3% in women. The people who died prematurely because of chronic renal disease caused by diabetes is 54% in males and 30.4% in females. In other words, an increase above 50% in the case of males. And in the case of years lived with disability, the dailies, there you can see the relative difference of only 1% in males and perhaps a bit less in females. But this isn't good news. The thing is, the people with chronic renal disease caused by diabetes are dying more, and they are dying prematurely. And that is why they are not having time to develop a disability because they die too soon. And so that is a concept that we need to further strengthen our control. Diabetes is a challenge in and of itself. But to this, we have to add the fact that diabetes can lead to other non-communicable diseases, coronary cardiopathies, peripheral arterial diseases, coronary disease, and you're acquainted with diabetic retinopathy, diabetic nephropathy, and neuropathies too. But these are chronic diseases, but they're also linked to communicable diseases. I'm not going to go into details, but there's also a strong association between tuberculosis and diabetes, and also with COVID and diabetes. In the case of tuberculosis, not only is there an increase in antimicrobial resistance that can be developed by people, but also it worsens the metabolic control for diabetes. So the diabetes has an effect on not only communicable, but also non-communicable diseases. So how do we cope with this challenge? We have a very powerful disease that in turn develops other very powerful diseases, both communicable and non-communicable. And the best way to do this is by focusing on the person, and second, trying to integrate different interventions. And that is where PAHO's intervention comes in, which is better care for NCDs. Now, what do we mean when we talk about better care for NCDs? Our objective is to increase equitable access to integrated and comprehensive services for non-communicable diseases within primary care in the Americas. And we want to strengthen the ability to deliver these NCD care services, and we want to increase our capacity to detect, diagnose, treat, and provide ongoing care to people affected. And we need to strengthen data gathering. We need to have sound, timely data that would feed into decision-making. This is a diagram that represents a house, and here you can see all of the diseases that are part of this initiative. You're going to receive the QR code later on, but right in the middle of the picture, we have diabetes. That is our topic for this morning, for these 2 days. And our initiative of Better Care has 6 different priority areas, strategic areas. They go from operational plans, strengthening interaction with the community, improving the ways that we cope with this challenge, also increase the technical capability of the teams involved, increase access to medicine and technologies, and to improve our care for non-communicable diseases. That is something that wasn't drawn out of the air. It's something that we have engaged in based on a lot of evidence. On the screen, you can see some of the technical papers, some of the publications that are part of this initiative. And please do go to our website so that you can see this information. Now, in specific things having to do specifically with diabetes, here we have colleagues in the audience, people that are connected remotely are acquainted with this. This is following the HEARTS-D model for diagnosis and management of diabetes. Then we have guidelines on second and third line medicines for diabetes. So that was published by WHO. And I always like to include this model list of essential medicines, because in this model list, all the evidence backing up the decision to incorporate or not incorporate certain medicines in the not only treatment of diabetes, but for any pathology. So those of you who are interested, those of you who want to know why we recommend certain medicines and not others, will find all of the evidence we have used in that publication. We also recently published this publication on Best Buys. It goes back quite a way, but it was updated. And please do look at the Best Buys publication. And we have to make certain that countries can have the necessary resources to implement HEARTS-D or to provide the best care for NCDs. Here, we have the essential medicines and basic technologies, including glucometers and also blood pressure cuffs. Now, here, self-care is essential, we have been publishing documents that address the people living with the disease. We have two publications. They are in English, Spanish, and Portuguese. The first publication has to do with self-care, and the second publication has to do with physical activity of those living with diabetes. So we are currently working on a publication on mental health, and I hope that it will soon be available to all of you. And also, I want to stress that in addition to the evidence that is being published, I showed you the Hearts D, the guidelines on treatment from WHO, and the model list. We're also working on developing a guide to treat diabetes, and all of that for primary health care, including the experts from all over the world.
These are the key messages I would like you to take away today. Please think about this after the seminar. Once your adrenaline comes down, the prevalence for diabetes increased fourfold in recent decades. The Americas has a huge gap in providing diabetes treatment. The disability caused by diabetes is rapidly rising. Premature mortality and mortality caused by chronic renal disease from diabetes is also increasing drastically. And at the base of all of this, we should remember that diabetes is preventable and controllable by using evidence-based strategies and a public health approach. There's one last thing I'd like to say. It's a personal message I got from my grandmother. We can always go faster, but we can go farther if we work together, not just farther, but we can get sustainable results. So when we look at diabetes numbers in 5 years' time, let's say we hope that we won't be repeating the same message, that coverage is not adequate and that more people live with this disease. Thank you. Excellent presentation. Thank you very much to Dr. Carmen Antini, the regional advisor from PAHO, for a very comprehensive presentation on the diabetes landscape, looking at prevalence and disability, among other things, and the importance of focusing on the existing gaps to improve treatment and control of diabetes. That, I think, is the key message for all the discussions we'll be having over the next 2 days. How can we close these gaps in access to care, medicine, technology? And the evidence is there, the interventions are there, but what is missing may be the know-how, the how to implement. And that is where research comes in, research that can be implemented. And that is why we are here to launch the new research agenda for diabetes. And we'll invite Dr. David Buran from the Geneva University to present.
Over to you, David.
Thank you, Silvana. I'd like to thank Dr. Hennis for his words of welcome, and also the collaboration between Silvana, Carmen here in PAHO, as well as colleagues from WHO headquarters, Bianca and Goika in this work, and then also colleagues at the University of Sydney, Professor Stephen Caligiuri and Emma Cox. So I've been given the challenge to present from research to care and this issue of evidence in care, and how do we improve diabetes care. We've seen the numbers globally and from PAHO, and this is clearly a challenge. And what role can evidence play in addressing this? So just in the interest of transparency, here are my declarations. I've carried out different consultancies and advisory roles for the World Health Organization. I'm the co-lead of the Addressing the Challenge and Constraints of Insulin Sources and Supply study with Health Action International, which is supported by the Leona M. and Harry B. Helmsley Charitable Trust. I've received funding from the Swiss Agency for Development and Cooperation, funding from Breakthrough Type 1 Diabetes, and also a visiting professor grant from the Danish Diabetes Academy, not related to the issue of access to insulin. And I think most importantly, the views that I expressed today are my own and don't represent any of these funding sources or my institution. So I think when we talk about evidence, this evidence has to be generated, and most of the time it comes from academia and from research. This then hopefully influences policy practice, and there's a back and forth that comes in. But often this doesn't happen. Practice can be influenced by other factors, policy as well. And there's this whole issue of who's transferring the knowledge, how is this knowledge transfer, who's brokering this knowledge, and then of course there are other influences that can come into this. And many of you will be familiar with this pyramid of evidence in the sense of what do we talk about when we're looking at evidence, the truth, validity, and then also how is this translated into policy and practice. So how are expert opinions, which can be seen as not high on the scale of evidence, how are they seen versus systematic reviews if I'm a policymaker? And if I have an expert walking in my door, do I see that differently? Because clearly I'm not going to be reading systematic reviews. So it's also to think about this issue of what is evidence and how is it transmitted? And in thinking about this presentation and the challenge that my colleagues, Carmen and Bianca, gave me in presenting this, I thought of this concrete example, which I think is very on the agenda, both globally and here in the PAHO region, this issue of human versus analog insulin. And I think the important point in this presentation is I'm taking a public health approach. I'm not taking a clinical approach. I'm not taking the focus of people with diabetes, what might be best for them or what they want, but really focusing on this public health perspective on this issue. And I think it's also important is recognizing that insulin, as all of you know, is essential for type 1 diabetes. Without insulin, people will unfortunately die, but that most insulin is used globally for type 2 diabetes, where the need is less clear sometimes and is determined by guidelines, by clinical practice, by a variety of factors. So coming back to that pyramid, if we take the highest level of evidence, we have two Cochrane reviews, looking, one published in 2020, well, both published in 2020, looking at the impact of these analog insulins versus human insulin. And what we see from this evidence is that the effects on HbA1c are comparable. Treatment with insulin glargine and insulin detamir, so two long-acting analogs, resulted in fewer participants experiencing hypoglycemia when compared to NPH insulin, so human insulin. However, serious hypoglycemics were rare. Also, this systematic review reports that most trials did not report patient relevant outcomes, so the perspective of individuals with diabetes are not taken into account. And if we look in type 1 diabetes, we see that there are no benefits or harms for severe nocturnal hypoglycemia, and there was no true beneficial or harmful effect of the intervention. So if we look at this evidence that's generated, that there is no difference between the two types of insulin, long-acting analogs and human insulin. But then the idea is, how do we translate this dry evidence into policy? And I think it's interesting as an outsider to the World Health Organization to see this evolution over time of this translation of evidence to policy. So in 2001, the expert committee of essential medicines highlighted that insulin analogs currently offer no clinical advantage. So reflecting that evidence that was developed later. In 2017, again, this element of small magnitude of benefit, and in this case, also mentioning the high price. In 2019, again, this element of the evidence showing efficacy and safety advantages of analogs compared to human insulin, but there's not large enough to justify the difference in price. And then finally, in 2021, the inclusion of long-acting analogs into the essential medicines list. With this focus on people who are experiencing high hypoglycemia. And again, the evidence being highlighted by being not so great, that most clinical outcomes were small, that this, again, highlighting this issue of price, and that there is this need to really focus on this subgroup of people with at risk of hypoglycemia. So clearly there's one issue there's a few issues that come up if we look at how that evidence was translated into practice. There's the issue of the evidence that there isn't much difference. There's the issue of the price. And then there's this issue of hypoglycemia. And so the issue raised by the expert committee in 2021 highlights this issue of hypoglycemia with human insulin. and this incidence of symptomatic and nocturnal hypoglycemia. But if we go back to the evidence in the Cochrane review, it highlights that there is no benefits or harms with regards to the specific acute complication of diabetes, which is nocturnal hypoglycemia, beyond the issue of how do we actually measure nocturnal hypoglycemia, especially in contexts where healthcare worker training, access to certain technologies is low. So if we follow now, if we say we have this evidence has now been translated into policy within the WHO Essential Medicines list. If we're not going to translate this into practice, we need to think about how then do we identify these people with nocturnal hypoglycemia, which is a severe complication, and then provide them with this better treatment. And again, that's very difficult to do and highlights this issue of translating this policy into now practice. If we look Carmen presented the HEARTS-D and looking at the guidelines. So for currently within the guidelines, the element is to focus on human insulin. And I've highlighted in yellow the footnote, which is insulin analogs are not recommended for routine use as they're substantially more costly than human insulin, and there is considerable uncertainty over their benefits, especially in people with type 2 diabetes. And I know that Bianca and colleagues are currently working on guidelines for type 1 diabetes, so we'll see what the recommendations are for the use of analog insulins in type 1 diabetes. So that's, for me though, that's one part of the evidence. And I think coming back to the opening remarks of this panel and Carmen's presentation, there are many barriers that exist. So barriers to insulin access persist globally and again, also in this region. We have a rapid increase in the prevalence of type 2 diabetes. A full package of tools and services is needed to effectively manage diabetes, not just insulin. We are dealing with a market that is dominated by 3 multinationals. And how do we deal with the element of in public health, dealing with market forces? Analog insulin is substantially more expensive than human insulin, and the costs of managing diabetes are significant for health systems and individuals. And I think the next few slides will present this other evidence that I believe we need to take into account beyond the clinical evidence of just the medicine itself. And really to think about, and this is a figure from the WHO used originally for antibiotics and the pathway for antibiotics, but I think it's a useful framework for insulin, is that if we look at research and development all the way to use, there are barriers that exist at each of these levels. And again, evidence exists for all of these levels, and how do we take into account this evidence when we're planning and responding to the global diabetes challenge? So this is some data. It's a bit dated, but it highlights the dominance of 3 manufacturers. So in dark blue, we have Eli Lilly. In red, we have Novo Nordisk. In green, in Sanofi for different income groups. And we can see overall in most income groups, especially in high income and upper middle income, clearly the dominance of the big 3. In lower middle and low income countries, there are other manufacturers that we know of, and there are some manufacturers in the PAHO region. If we look at the prices of insulin, which again is, for me, part of this evidence and was highlighted by the expert committee many times when looking at the difference between human and analog insulin, what we see, is a significant difference between the estimated cost of production and the government purchase price. So the estimated cost of production is between $2.28 and $3.42, and the median price for government procurement in these countries listed is 5.9. The other element to take away is the wide range of prices that exist for the same product. So if we look at government procurement prices for human insulin, they range from 1.45 to just under $25 per vial. And then finally, as was highlighted by the expert committee, this difference in price between human and analog. So we can see in some countries, insulin is provided for free, so that's why the patient price is 0. But if we look, for example, just at the median prices for human versus analog insulin, we can see the median purchase price when people have to pay out of pocket for human insulin is $4.35, and it's significantly higher with over $31 for analog insulin. If we look at the cost also for the health system, and this is real data from a low and middle income country, we can see here in the table On the left side of the slide, this is the government procurement prices for different human insulin formulations and then analog insulin formulations. And what we can see is that analog insulins on average are 8.8 times more expensive per unit than human insulin. In this country, insulin is provided for free, but not enough strips for self-monitoring. And if we just take this assumption of 13 vials per year for a person with just type 1 diabetes, human insulin for the people with type 1 diabetes in this country would amount to $109,000 US. If we use only analog insulin, it would be approximately $962,000. So it's a difference of $853,000, and that's just for type 1 diabetes. So it's not including people with type 2 diabetes, and this is just for insulin. And I think this is part of the evidence that we have. And the question would be, what would we do with this difference of $853,000, given all the challenges that were mentioned by Dr. Hennis, by Carmen? Would we change? Would we say we'd move from vials to pens? Would we want to purchase analog insulin? Would we invest in self-monitoring, or would we invest in strengthening diabetes care overall, or other measures? And then, as we all know, in many cases, the price of insulin is not paid for by the health system, but by the individual. And again, this is a mix of data sources, but just to show that if we look at the price, the cost to the individual, assuming their monthly salary, for human insulin in different countries, this would represent anywhere from 1.5 to just close to 6% of their monthly salary. And this is the salary of the lowest paid government worker. If we move to analog insulin, we're significantly higher, ranging from 11% to over 40%. So again, this financial burden cannot be neglected. And I think what's interesting, coming back to the use of evidence and moving forward on this issue of access to insulin and medicines more generally, is the recommendations and the translation of the evidence that the expert committee had in 2019, highlighting the need to address these different facets of the barriers of access to insulin. Not just is one better than the other, but how do we address the market? How do we look at regulatory aspects? How do we look at pre-qualification? How do we look at procurement and these wider factors that are needed to be addressed? So just a few concluding thoughts. How do we address this issue of clinical evidence versus evidence about the market and its dynamics? And I think it's hard for us in public health to think about markets. We're not used to dealing with markets in the private sector. How do we use all the evidence that we have at our disposal to impact policy and practice, and not just one piece in isolation? Not just saying medicine A is better than medicine B, but what does it mean for the overall market? What does it mean for people with diabetes? What does it mean for health budgets? And also that advocating for analog insulin has impacts beyond the individual. Clearly, as people who are interested in diabetes, we want what's best for people living with diabetes, and that's what drives us every day. But that advocating for something, be it analog insulin, be it continuous glucose monitors, be it specialist diabetes nurses, has an impact on health budgets. And if we're looking at products that are produced by the private sector, that has an impact on the market. We also have to think about when we talk about cost effectiveness works if the health system is providing it. Because what I'm interested in as a decision maker is A, more cost effective than B. But if I'm a person that needs to pay out of pocket, that doesn't matter if A is better than B. It's what can I afford? And again, this element of affordability for health system budgets and also household resources. And I think we now have this added challenge of GLP-1s, so these new medicines, and what do they mean for the insulin market and for diabetes in general. And I just wanted to end with this one quote was presented in discussing universal healthcare coverage in Thailand, which is often quoted as an example of a middle-income country enabling coverage in a rational way. And this quote from this book on the history of universal healthcare coverage in Thailand, I think is very relevant, is all decisions need to be guided by evidence and process, should be sensitive and able to make use of evidence rather than merely political calculation or personal preferences, experience, or ideas. So with that, I thank you all for your attention and for your participation in this launch of the research agenda, which I hope will add more evidence and broader evidence to a variety of topics. So thank you again.
Thank you, Dr. David Baran from the University of Geneva in Switzerland for presenting these important data on not only the clinical evidence around analog versus human insulin, but the differences in price, which are astounding. And then bringing up that really important point that it's not just cost effectiveness, but it's also about affordability to government health systems, affordability to individuals. And I think we'll have a lot of opportunity in the next panel and in subsequent workshops to talk about how can we create greater accessibility, affordability of these effective medicines and technologies for diabetes and reduce that treatment gap. So thank you again. So now the moment we've been waiting for to learn more about this global new diabetes research agenda. And we have Dr. Gojka Roglic connected virtually. She was unable to travel to Washington, D.C. Gojka, can you hear me?
Yes, thank you, Anna, I can. I hope you can hear me.
Yes, I can hear you very well. And thank you, Gojka, for joining us. Gojka used to be the head of the WHO diabetes program, since retired, taken over by Bianca now. But Gojka continues to provide her expertise and skills to the global diabetes program, leading this work on the research agenda. So over to you, Gojka.
Thank you, Silvana. And thank you to PAHO, to Anselm, and to Carmen for hosting this event and organizing it. It's always quite a task to organize such an event. And I'm happy to participate and with this launch, or maybe launch is a sort of too fancy word, but if I could have the next slide, please. I think you have all heard the introductory part. I wouldn't need to go into the burden of diabetes, and we all know that. That's why the audience is here and all of us are here. Can I have the next slide, please? So we decided to look at what the priorities would be in diabetes research, and there is now WHO guidance on how to do it. And ultimately, it boils down to that there is no gold standard on how this should be done, but there are several ways, several methods, and they each have their own advantages and disadvantages. In the past, it has been done with a consensus-based approach. A small group of experts got together, and then they produced a document. We had decided to use a metric-based approach, meaning basically scoring. Next slide, please. And the whole exercise is a technical collaboration. WHO has convened a group, and it's the University of Sydney that is a collaborating center for diabetes. University of Geneva, which is David is in close proximity and is always helpful and eager to engage. And the logistics was supported by the International Diabetes Federation. And we're grateful to the funding from the United States CDC, from the Geneva Science Policy Interface, and the Leona M. and Harry B. Helmsley Charitable Trust. Next slide, please. So the method that we had decided to use was something that has been developed for a different purpose for the child health, nutrition, and research initiative. But it has been since 2008, it has been used for similar exercises within WHO, and it is a sort of more quantitative approach and gives an idea of the level of collective support for a certain research idea, and the variance in the opinions, and the extent to which the experts agree when they judge the merit of a research question. Next slide, please. So we started with gathering research ideas, and we did an online survey requesting people who have been approached as potential participants, please let us know up to 10 research topics that you think are priorities or very important to be resolved or answered by the year 2030 for improving diabetes prevention and care in low and middle income countries. So the context, timelines, and the target population is basically that of the Global Diabetes Compact. Next slide, please. And we have spread the nets high and wide to capture people, to invite people to get to do the survey. The technical advisory group for diabetes helped with suggestions. They themselves also provided their ideas. We have WHO collaborating centers. The International Diabetes Federation also helped in recruiting participants that would provide ideas. International professional association members like ADA or ESD, the Diabetes Compact Forum, which has many members. We approach major humanitarian agencies. They are increasingly interested in non-communicable diseases and diabetes and have particular circumstances in their field of operations. International diabetes patient associations, research funding bodies, and we scan journal articles for authors in this 2-year period, major diabetes-specific journals, and a couple of those big general journals that do frequently publish breakthrough research or milestone research on diabetes. Next slide, please. The next way, the number 2 of how are we going to get research ideas was to do a review of the Cochrane reviews published in this 10-year period that you see on the screen. And from the sections of implications for research, we extracted all the questions that were in these Cochrane reviews. And finally, the number of WHO diabetes guidelines is not huge, but each of these guidelines does mention research questions that the guideline development group had thought would be worth addressing. Next slide, please. So we invited more than 300 people. It was probably more than 400 people. The response was 94 people from 45 countries. We had initially approached almost half the global countries. The response was not huge, but still we got responses from 45 countries, and they provided more than 500 research ideas. Some of them were not even research ideas. Some of them were like recommendations of what should be done rather than what should be discovered or answered. So it took a while to sift through all this input. And from the Cochrane reviews and WHO guidelines, we got about more than 150 questions. Next slide, please. So when it was all cleaned up, when the duplicates were eliminated, when the rewording was organized in a way that it would be more standardized, the curated research questions or ideas boiled down to 65 of them. Next slide, please. WHO in their documents uses these main research categories. However, these are not obligatory categories, but we found them convenient to organize the research questions into these categories. The questions about the problem, like what is the size of the problem? What is the burden? The cause, understanding the causal agents and determinants, like what causes type 1 diabetes, for example. The solutions, what new interventions or tools or medicines are desirable, would be needed. Then evaluation, how do we evaluate the effectiveness of the health impact of an intervention? And finally, implementation, how does one translate new interventions into policy and practice and to understand the barriers to delivering known interventions? Next slide, please. So probably not surprisingly, most of the questions were about describing the problem and finding a solution. Quite a few about the cause, the evaluation, and only 5% were about how do we implement interventions that have been proven but are not being implemented. Still, there were nevertheless some questions on implementation. Next slide, please. The group of questions, the mass of questions that we got together can be, of course, divided in many different ways. We have also divided them by type of diabetes, which is a natural way to divide up the number of questions, but then they can also be broken down by different topics, complications, access to medicines, management, comorbidities like TB or COVID, prevention of diabetes, capacity building. What about screening? What about stakeholder involvement? So these are all categories that these questions can be pigeonholed into. Next slide, please. Most of the questions were pertinent to all types of diabetes. Then type 2 diabetes, 11% of the questions were specifically on type 2 diabetes. Type 1 diabetes, 1% of questions were specifically on type 1 diabetes. Could be reflecting the actual size of the burden. There are many more people with type 2 than with type 1. And 3% of the questions were related to hyperglycemia in pregnancy, be it diabetes or gestational diabetes. Next slide, please. So what would be the criteria for scoring the research questions, for giving them what is important? What criteria do these questions need to satisfy? And of course, there could be an infinite number of criteria that one can use to judge whether a question is important or how important it is. And we sought advice from the WHO Technical Advisory Group on Diabetes to limit the number to a manageable number. Otherwise, people will not feel like scoring 65 questions by more than a handful of criteria. The response rate would certainly be very poor. So the decision was that these are the criteria on which the questions would be judged. Significance. Is the question important? Does it need answering? Because it might have already been answered. Answerability. Can an ethical study be designed to answer this question? Feasibility. Can the study be done in the context, given the complexity, the infrastructure, and the time frame of the Global Diabetes Compact? What is the potential impact on the diabetes burden? And what about equity? Would everyone benefit, not only high segments of society, but underprivileged people as well? Next slide, please. The expert scorers, we had invited almost 300 expert scores on the basis of their publication, recent publication record. And 104 had agreed to participate. And you can see on this slide that there is a representation from the whole world. Also, that there is a difference between where people reside and where people have had work experience. And we asked that question because we thought was relevant of whether, regardless whether someone lived in the United States, but if they had spent 10 years working in sub-Saharan Africa, they do have a feel of what is happening there. So not surprisingly, many of the scorers were from Western Europe. That is where a lot of research does happen. We did manage to get quite a few people from sub-Saharan Africa, and we made an extra effort to get people from low and middle income countries, because that, again, is the context of the Global Diabetes Compact. Next slide, please. Then the question comes like, what is the role of non-expert stakeholders? There is a lot of talk about we have to engage people with diabetes, people with lived experience. We have to engage policymakers, and it wasn't feasible to have people with diabetes or policymakers who might have contributed to research ideas. It wasn't feasible to have them ask whether questions which required considerable expertise, whether something was feasible, whether there is a design that exists that can be done, whether that question is important and has not been answered already. So the engagement of stakeholders was through giving them the opportunity to weigh the scores of the prioritization criteria. And the IDF helped us through their newsletter and social media to find people with diabetes, the Global Diabetes Compact Forum members, the Technical Advisory Group for NCD's Research and Innovation, who are not diabetes experts, some people funding bodies, and then individuals who we personally knew. And we got response from 89 people from 35 countries, half of them from our high-income countries and the rest from middle-income and low-income countries, mostly people with diabetes and their family members, but there were people from the media, lawyers, policymakers, research funding bodies, NGO officials, non-diabetes professional association, and non-physician healthcare workers. Next slide, please. And this is how the criteria have been weighted. While the Technical Advisory Group for Diabetes assumed that each of these criteria had equal weight, the non-expert stakeholders obviously gave more weight to the impact on the diabetes burden and to the effect on equity. Interestingly, the answerability was not a sort of major issue for non-expert stakeholders. So the criteria will then adjusted according to these weights to arrive at final scores. Next slide, please. So we come to the meat. The top 10 research questions. The first question that scored the highest, where almost all of the scorers agreed on all that it satisfied practically all the criteria, was related to hyperglycemia in pregnancy. and specifically including gestational diabetes and in resource-poor settings. It is indeed an issue. It's a tension between public health and individual benefit. And when you have a condition that has about 10 different diagnostic criteria and at least 5 different recommendations on screening or on treatment, this is probably worth resolving for a global recommendation. The next, number 2, is related to barriers to access to quality, affordable diabetes medicines and delivery devices, and how to remove these barriers. That is also a perennial problem. David has talked about it, and it is not only about insulin. It is about even generic medicines for diabetes that should, by all accounts, be affordable for everyone, and they're not. So how does one resolve that? Number 3, studying barriers to implementation of established and new diabetes interventions. So there are interventions that have been proven to work, that are not very questionable, but they're not being implemented. And so this would be implementation research question. Next slide, please. Using community health mechanisms to improve diabetes prevention. How does one use? There are community health mechanisms. They're not being used. They're being used for infectious diseases. For diabetes, they're not. So can they be harnessed? Then developing methods for delivering health education to people with diabetes in low and middle income countries. Is there a way to do that and be successful? Next question is identifying cost-effective models of diabetes care in low resource and humanitarian settings. Next slide, please. Identifying health system challenges for diabetes and how to address these health system challenges. That is also a perennial question that has been around for a while. Developing and applying methods to measure and monitor the health and economic burden of type 1 and type 2 in low and middle income countries. There is a lack of data on many of these aspects, complications particularly, and mortality. Number 9, developing and evaluating approaches to improve the early detection and prevention of cardiovascular disease and other diabetes complications. This stems from the fact that a low proportion of people with diabetes do actually receive preventive intervention for cardiovascular disease. And also for complications, there are ways now that have to be explored to detect and to manage other complications like retinopathy or nephropathy, but that are affordable and are suitable for the population they are in low and middle income countries. Next slide, please. And how to improve diabetes prevention and management in primary health care. So these are the top 10 research questions, and there wasn't any discord between the scorers. They all sort of agreed on how they scored, the importance of each of these questions. So there wasn't any need to discuss the discrepancies in their judgment. Next slide, please. If we break it down into diabetes themes, then these are the top questions in certain themes there, but they're not in the top 10 that I've just shown. but there's still the rank is in this middle column. And regarding prevention, it is to answer the question, what are the interventions to reduce diabetes risk in people that have not been identified by IGT? Because the evidence on prevention that is based on glycemic values is limited to people with impaired glucose tolerance, which, as you know, is a complicated test and is not routinely performed. Another question is what are the different presentations of diabetes in low and middle income countries and the underlying pathophysiology, molecular phenotypes, therapeutic responses, because the current classification is not satisfactory. It just doesn't cover all possible presentations of diabetes. So then some categories are fuzzy. Regarding management, evaluating and developing technology, a lot of it is being developed. Not that much is being really evaluated for use in low and middle income countries. Monitoring, establishing indicators for quality of diabetes care and methods for their monitoring and evaluation. And economics, well, what is the cost effectiveness of opportunistic screening for early detection of diabetes? And does it reduce the proportion of undiagnosed diabetes? Is it cost effective? And what is its impact ultimately on the outcomes? Next slide, please. And then we had a qualitative component about identifying barriers in translating research to policy for diabetes. And the rest of the meeting will be, this will be discussed in some of the workshops. Ultimately, we know a lot about what needs to be done. There is a lot of knowledge around, but it is just not being translated into practice. And the University of Geneva has supported this work and conducted this work. Next slide, please. And it was done through interviews of various stakeholders from the 6 World Health Organization regions. And the questions were, what is the policymakers' knowledge of diabetes? What are the research, how are the research priority decisions being made? What is considered in research prioritization? Who is involved and why? And how does the translation of research into policy occur in their experience? Next slide, please. And there were 26 interviewees, 12 policymakers, 6 research funders, 4 managers of research institutes and researchers, and 4 advocates from all WHO regions. Next slide, please. And the main finding is that policymakers outside the health sector often lack knowledge of diabetes and do not perceive it as a priority. Diabetes is complex. Indeed, it is. There are several different diseases with different approaches and different etiologies and pathophysiologies. There are many other challenges in low and middle income countries, and research funding bodies and countries themselves use different criteria and methods to determine the importance of particular research topics. Next slide, please. This exercise has its limitations. There is uncertainty over how well all the responders represent the global diabetes research community, particularly in middle-income countries. The responders, of course, the responders are people who have a computer. That is already a self-selection mechanism. And the response rates were low. Next slide, please. However, the methodology says that the number that has been achieved should be sufficient for capturing collective knowledge and opinion. We are reasonably confident that the responders represent a variety of settings, expertise, and opinions. We're not 100% sure. Next slide, please. The immediate next steps will be a publication in a peer-reviewed journal with more details on all of this and the list of all the received questions. And then it is planned to evaluate the uptake of the diabetes research agenda, the top 10 questions. So I thank you. Next slide, please. Thank you for your attention.
Wonderful. Thank you very much, Goika. We really appreciate you running through the methodology as well as the top 10 implementation research questions. And we especially like the focus on how do we translate that evidence into policy and practice, which is what we're going to have a lot of time to talk about in the next panel and over the next 2 days. I also want to acknowledge that we have here in the room Dr. Emma Cox from the University of Sydney, who was also an integral member of the development of this global research agenda on diabetes. And we'll hear a lot more from her throughout the 2 days of the meeting as well. And if we have any questions for her and the methodology and how the questions were determined. And of course, those questions are standard questions that have existed for many, many years. So it's not surprising that they made the top 10 list. And again, we look forward to the discussions on how we can help answer some of those questions. But that will conclude this first session of our presentation. So I'd like to thank all of our presenters, Dr. Carmen Antini, Dr. Bianca Hemmingsen, Dr. David Barron, Dr. Goika, Roglic, and thank you very much. And I'll ask you to take your seats. And we're going to switch now to the next set of panel presentations. And I'd like to invite our panelists up to the front table, Dr. Jill Louise Farrington, Dr. Percy Herrera, Dr. Maria Lucia Correa, Dr. Simon Anderson, and I think we have connected Dr. Kwamivi. Are you connected?
Yep.
Oh, great. Welcome. Oh, great. Hi, nice to see you. Thanks for connecting virtually. Sorry you couldn't join us here in Washington. Oh, yeah. We'll just take your seats and then we'll adjust the names on the signs accordingly. Yes. Thank you. Prof. Anderson. And do we have Dra. Correa? Adelante, por favor. Gracias. Y Dr. Herrera. ¿Dónde está? Oh, gracias. Adelante, por favor. Gracias. So we have a very distinguished panel that is going to speak. ¿Y vas a hablar en portugués? It's like we have simultaneous transition, so you can speak in Portuguese. Oh, questions. So yes, thank you. We're doing this next panel, which is going to focus on building that bridge from research to improving diabetes care through implementation of some of the evidence. And here in our panel, we have Dr. Jill Farrington, who's from the WHO European Regional Office, who leads the program on diabetes and cardiovascular disease and brings a wealth of experience on translating evidence to practice in the European region. Next to her, we have Dr. Percy Herrera from the Ministry of Health of Peru, where he's leading the national NCD program, which includes strengthening the diabetes component and improving care for people with diabetes in Peru. Next to him, we have Dr. Maria Lucia Correa from the University of São Paulo, Brazil, a leading researcher on diabetes in Brazil and regionally. And then next to her, we have Prof. Simon Anderson from the University of West Indies, based in Barbados. And we're really pleased to have all of you here joining us in this panel. And this is meant to be more of an interactive session to talk about the different experiences in different country contexts around the world and in our region. We saw a lot of the research questions that ended up being prioritized or around how do you improve care, how do you reduce that treatment gap in low and middle income countries, recognizing that the health system challenges are unique, that every country has their particular disease burden and profile of diabetes, but their particular circumstances around the health system, around the financing of the system, around the providers, provider capacity, around the primary health care and the public health approach to diabetes, as well as the interest groups that are available, or the civil society groups that are available in different country contexts to help accompany the government and people to improve care for diabetes. So I just want to start, because the main purpose of our webinar today was partly to launch the new global initiative the new global research agenda for diabetes, I just want to start by having our panelists comment a little bit from their perspective on what they think of those implementation research questions and how it can help. If we get answers to all those TED questions, how can it help you in your sphere of work, whether it's through research programs, academia, civil society groups? And I'd like to start with Dr. Farrington. Over to you.
Thank you very much, and thank you for inviting me, and a pleasure to be here. I mean, for those who don't know, the European region is 53 member states, and we range from low middle-income countries to high-income countries. And as you saw, that Western Europe can be quite prominent in the voices in terms of diabetes. I mean, first, I'd like to say congratulations on the document. I really enjoyed reading it and seeing the presentation, and it comes across to me as a very thorough piece of work. And also relevant. I think when I was invited to the meeting and I heard there was a document about research on diabetes, I was a bit worried that it was going to be kind of laboratory research and not very relevant. And what do I know about research? Why am I being invited? And then I was actually quite relieved to see the categories that were being used, and that many of them were categories that I was actually trying to do research in, particularly around implementation and evaluation. So I spend a lot of time trying to work out how do we implement known interventions in an effective way in countries, and how do we measure impact that we've managed to do that well. And so I could see those things in there. And I could also see some of my favorites in the top 10. Of course, they're the ones around implementation, but I think the number one for I don't know what to do was around the gestational diabetes, where we've had projects in low-income countries, and we've been asked, so how do we screen for diabetes disorders in pregnancy? And we've said, well, it's not really clear how to do it. And so it was interesting to see that something that's really troubled us in Europe was also in there. And I guess just to finish, the question for me now is, so what do we do? What's our part in addressing these research questions? Because I think they range from something that might go to a big funding body and a big piece of research, down to how do we build this into our everyday work within countries and contribute to the answers that could be useful for other people. Thank you.
Thank you very much, Jill. That is a question I think that we'll explore a little bit more. How do we use some of these research questions to improve our practice and policy? Dr. Rivera, en Perú hay gran cantidad de personas viviendo con diabetes. Yo sé que el gobierno...
A lot of people in Peru have diabetes, and I know that the government is making a major effort to close those gaps in terms of medicines and healthcare services. So how could a research agenda help you? Well, I think that was just mentioned by Dr. Farrington. We are trying to answer those questions too. We are seeing how we can implement them, but there is one aspect, something that worries us in the Ministry of Health, and I'm sure that I should share this. One aspect that concerns us in our country is that a lot of the interventions, although it's true, they do focus on the majority of the population. So in Peru and in other countries in Latin America, there is a lot of cultural diversity. And so not necessarily are cultural considerations included in dealing with that population. And that is something we're trying to cover too. So I think that that should be included. We have to look at cultural adaptation of some interventions so that vulnerable populations, and we do have a large vulnerable population, can also be covered. That's a very important point, and it's important for Brazil too. Brazil has a very diverse population. So, Dr. Correa, what would you say?
I work in a university. I think it's the most important university in Brazil. And
evento que o David me convidou na Suíça, é que me dei conta de como eu, como pesquisadora e como médica, não pensava sobre como traduzir ciências em saúde.
Didn't think about how best to translate the science into health. So I've been working in the area of diabetes for 30 years. I research this, and I never thought about that approach. So this is a huge problem, and this happens to me. And if it happens to me, I'm sure it happens to everyone who is dealing with diabetes and evidence. So I do come from a developing country, a low-income country, like all of our countries here, with that is a large continental country with much complexity. Now, we always say that São Paulo is like the Brazilian Switzerland because it doesn't really reflect the rest of the country. So I'm in an important university in São Paulo, and I hadn't thought about that. Imagine the other regions. So yes, this is indeed a very big problem. Now, the first problem is that we do have a lot of medicines available to the population, but we don't really have ongoing medical education for people. We haven't even established. That is what has already been established. We're not yet rolling out or carrying out. So imagine those new things. And so, yes, we are many steps behind the curve. And I apologize because I think that someone is creating evidence who's in the midst of this topic needs to be aware of this. It's a big problem. We have to understand why these different treatments and such are not actually translated into practical results and why people haven't been properly trained to treat patients. That's a huge challenge, and that's the reality we face.
Gracias. And Dr. Anderson, in the Caribbean, we heard earlier from Dr. Hennis, Caribbean has some of the highest prevalence of diabetes in our region. And we know the major challenges with small island developing states. How can a research agenda really help push the agenda and improve diabetes care for people in the Caribbean?
Thank you very much, and thank you for the invitation. I was really pleased with the list, actually. And I also was very pleased that it had questions around gestational diabetes as one of the major sort of first-line questions that we should ask. I think that the experience of the Caribbean is somewhat unique. There's a lot of mention of low-middle-income country, but only 5 of the Caribbean countries of the English-speaking ones that are affiliated with CARICOM and the UAE are low-middle income. The rest are high-income countries. But the resources are not available in those countries. So the actual attempts to do research will become, there's a lot of disparity. So countries like Jamaica will tend to get a lot more activities done compared to somewhere like Dominica, which has a unique characteristics in that it has indigenous communities in separate lands, as well as people who are sort of African origin populations. So it is possible to structure something around the research questions, but it's also going to be related to how much resources are going to be available. The problem is the size as well. There's an issue with how much people are in terms of technical capacity. I mean, you may have one person, for example, to manage mental health as a major island consultant in a country. And if that person is on holidays or something like that, you know, what do you do? So even though the questions are generic, there's an opportunity to really deep dive into how they may be specific for each territory, how funding might be more useful. And a lot of even though we have the highest rates, a lot of the data comes from very old data. It's probably higher than that. So for example, in Barbados, we did the last prevalence study in 2013, and we've just convinced the Ministry of Health to update that to 2024, 2025. So we'll have better data to share. And then that allows the ministries to deal with the problem of their financial planning. How do you get the resources across for everyone so that there's equal opportunity in terms of access to service? Even though there may be 1 or 2 hospitals in the country, the problems still remain that access to care is limited because of costs. So the questions are really very good overall. And I think that with a little bit of sit down and thinking it, make sure that we pinpoint the critical things as culturally appropriate as my colleague from Peru was saying, then we will be able to answer a lot of these questions as an ongoing basis rather than it being something that we do every 20, 25 years, which is what's happening in the region.
No, thank you for raising that. And I think the intent of having this global prioritization of the research agenda is to push more research and not just have it every 5 or 10 years. But I really like what you mentioned about being more specific. So I wonder if we could delve into that a little bit more, because one of the research priorities is to have a better understanding of what some of those health system barriers are to improving care for people with diabetes. And so, and again, the specifics depend on the country context and what's going on in the country. So I wondered, you know, in terms of the types of research questions and the specificity that would be required to better understand health system barriers, what would you recommend be the top questions for that? And Dr. Kwamavi, I see you connected online from the WHO Africa region, and I know you're leading a lot of work on diabetes and cardiovascular disease throughout the African region. Can you comment perhaps on the diabetes implementation research agenda and the specific needs for health system, better understanding health system barriers?
Thank you very much for giving me the opportunity. Happy to join this important workshop, and congratulations to the PAHO, office for organizing this. So speaking to the questions, and when we are talking about implementation research, as a comment, I wanted to mention one of the major gap. We want this document or this priority questions will help us to respond to. And one of the first one is, how do our interventions work in the real world? Like, how do we do more application based on what we have as intervention? So if you look at WHO have various interventions, you have the pen, you have the heartbeat, but in the real world, how this intervention works, especially in diverse settings, especially in low and middle income countries, where resources are limited. So I strongly believe that these questions definitely will lead us to that. And looking at the African perspective, where we have more low and middle income countries, where our major challenge is, how do we help countries, even with catalytic funding, to be able to, translate the WHO recommendation intervention to concrete action that can make impact. And then the second point may be also, how do we measure? So after doing the implementation, after translation, the intervention to action, how do we measure the impact of those interventions? Thank you.
Excellent. Thank you. Yeah, it's a really important point. We have a cadre of resources available, the Heart-ST module, the guidelines for diabetes, the new monitoring framework for diabetes. But the question is, how do we apply it, and what's the impact of applying these new tools in country contexts? Thank you. Jill, do you have any reflections on specific health system barriers that we need to better explore and then apply?
I think the challenges around diabetes are similar to challenges for other NCDs, and it's a piece of work that we've done within the European region in the past, looking at health systems challenges. But if I pick out one in particular, I would say human resources. If I think of some of the countries that I'm working in, there is a 50% shortage of family doctors, and a turnover of 40% of nurses during the course of a project that we were doing. And so if I think again of that example of something we were doing in Kyrgyzstan and Uzbekistan, two low-middle income countries, we're trying to implement simple protocols, improve diabetes care, prevent complications. We know what to do. We have a list of interventions, but it's a complex intervention. We're trying to measure change. We're trying to do interventions such as training, clinical support tools, et cetera, supportive supervision. So a whole range of different interventions and inputs. But during the course of that time, 40% of the nurses disappear, or there's medical migration or other issues. And so then we get back to, so in terms of implementation research, how are we measuring what our outputs were? We can measure from the medical records audit issues in terms of glycemic control or hypertension control. But what did we really achieve in terms of the intervention of trying to improve care in other ways? And what was the effective intervention? How much training was actually needed? How often did we need to top up training? If we had new nurses coming in, how did we need to do that, and so on? So if we take a simple issue of a human resource challenge, which cuts across many diseases, and we're trying to implement certain interventions, what's the best way to do it in such a dynamic situation? And how do we measure that we've really had an impact, which also benefits other diseases? So it's something that we're kind of grappling with. It wasn't what we expected when we set out. We set out with a nice kind of research study design, but now we're at the end. We're trying to think, how do we capture what happened and how do we best learn from that for going forwards?
Oh, excellent point. And I know that challenges with human resources, especially at the primary care level, are a recurring theme in all the countries, and especially in the Caribbean sub-region where we see a lot of migration of health workers, especially. And this issue of evaluating as you implement, I think, is a really critical and important point as well. And I would add, of all the things that the criteria to evaluate around time of training and the type of providers being trained, the issue of task shifting has come up, right? And I think that's another area that maybe we could also explore a little bit more to address the issue of the human resource challenges. But I don't think we've done enough with task shifting for diabetes. Dr. Herrera, no sé si tienes experiencia en el Ministerio de Salud en Perú.
Dr. Herrera, does the Ministry of Health in Peru have any experience in addressing barriers in the healthcare system, especially in primary healthcare? How are you dealing with that and how can research help? Thank you very much. In Peru's case, it's not just us. I know other countries may have a similar situation, but we need to go back a bit further. We start with people who are going to design public policy. They need to understand that they will have to implement policy and that research will be needed to do that. If we don't have that, we can't have normative documents that include strategies. If we want an evidence-based strategy, it has to be part of our normative documents. If not, it can be a management strategy, but it's not going to be a state policy. So we need to start at that level. It has to be written in our normative documents. And those documents have to be specific. They need to specify what budget items are going to be made available. It doesn't make sense if it's referenced in the normative document, but if specific activities are not listed, if we don't have products that are tied to the budget. And that is directly related with how to monitor, how to follow up this initiative. I can see whether it was implemented. I can see if the resources I allocated to different activities were budgeted or not. So it's possible to verify that information. And then when that specific activity is carried out, I can tell the entity or the staff to go ahead and execute. So that's another barrier I mentioned before, and also my colleague mentioned it. We have a huge issue, and it seems that other countries also have the issue of the turnover with our medical personnel. I can implement a strategy. I make sure that it's in the budget. I need to implement training. But if the personnel turns over, if people leave, that's extra work. It's very hard to have our official documents be clear enough so that the information can be used, and can be replicated given this turnover factor. So that's something we're trying to deal with in our country, and I imagine we will be looking into this later. The question is, who drafts the normative document? Who makes sure that the right information is there? Who makes sure there is alignment with the budget? And that it's easy to understand for the personnel to work with, given especially that high rate of turnover. Well, we're speaking of something that is going to apply to all non-communicable diseases, not just diabetes. We need to have a normative document. If we don't have that, if the information is not there, you can have an initiative that is pursued by an administration, but it doesn't become state policy. If it's not in the document, it's not going to be covered in the budget. All of that has to be aligned. So it's institutionalizing all of this, if you will. Thank you very much. Dr. Correa, in Brazil, what are the main barriers systems are facing and how do you deal with them?
I believe we also have this issue with the human resources. Almost everything is on the medical doctor, and we also have this turnover. There are guidelines to help the doctors in how they work with all the diseases and complications, but we don't know if this is effectively implemented. There are standards, there are guidelines, but there aren't necessarily programs so that we can make sure that the doctors are learning them. So there is a gap between what is written on paper and what is actually done. And some of the metrics are, for example, 2 HbA1c per year, but then you don't demand a right number below 7, for example. So, okay, it's twice a year, and this is being followed, but this also is related to the result. You can't just say you need 2. What are you doing to improve this? We also have our community agents that work in health in Brazil, and they could be better used because everything is usually given to the doctor, but I think nurses and community agents could be doing more.
Better and more fully for diabetes and for NCDs overall. I think we saw during COVID how effective the use of community health workers were, and perhaps we need to explore that a little bit more in the NCD and diabetes communities. And then you bring up really important points about the quality of care metrics and how we're monitoring them. And that was one of the research questions, right? So I think that's something also that we need to be mindful of, whether we're in research community or whether we're in a government or civil society or a funder, but how do we cultivate that quality perspective and delivery of care, and how do we make sure that we're monitoring it, whether it's through clinical audits, whether it's through clinical supervision, but having the procedures and processes in place. No, very good points. Thank you. Dr. Anderson, for the Caribbean, the big health system barriers other than HR that we've talked about.
Yes, I think that one of the solutions to the barrier system that we have is having a community-led approach. So for myself and colleagues that we're working in research at the moment, we're approaching research from the community's perspective rather than us being paternalistic in terms of what we think should happen in the community. And what that means is that it allows us to enable capacity building at a faster pace, because we're bringing the young people with the research, but we're bringing the mindset that we're not doing a long-term succession planning, we're doing a short-term succession planning. So we expect that nurses will go, we expect that doctors will go, but because the task shifting is uniform across the community, and the community gets to own the activities and the implementation process, as well as the researchers and the ministries, it means that feedback evaluation can be updated throughout the process. The other thing that I think we should contemplate is making sure that as we train people, they understand that they themselves must hand over the reins of information and knowledge and that we accept the new technologies as part of the process for getting things done. So, for example, if we're going to use a community health nurse, a community health worker or a nurse, or some other allied to medicine or nursing specialty, we should make sure that they're really updated. We have the knowledge base for them, knowledge hub for them to use to get updates, and that they don't feel as if they're excluded from the learning and the knowledge transfer that needs to take place all the time. So that's what we see. And we have actually 3 projects that across the Caribbean that we're planning to implement this strategy in Dominica, in Jamaica, in Guyana, and in St. Vincent. That's in relation to looking at outcomes from moms who have diabetes in pregnancy, but are forgotten after the pregnancies is over. Yes. And then to look at implementing some of the work with barbershops and churches.
Excellent.
As part of the team, to making everybody sort of the community scientists, so to speak, in terms of dealing with some of the issues. Because as we've said here, the resources are limited, and as I say, the workers are few. So you'll find that the same people may be doing a lot of the work, and that's a huge barrier because it means that things can't move at a pace that we'd like. So if I'm here in Paho and I have activities that needs to take place in Barbados, that's a limitation. But also in our community, which is regional, we want to share the knowledge that we get from the activities that we do. So it's not just something for diabetes, and we can share it with other conditions as well, especially since we know that a lot of people have multiple long-term conditions, which with the NCDs that they suffer. So I think that may be a strategy. We don't have the findings yet. That's what we're trying right now to see if we have a more comprehensive way of dealing with research from the community's perspective. So letting them understand that we're not there to test research on them, but that this is part of them having a longer, better life than having to just deal with the conditions when they emerge.
Yeah, that's excellent. How to and foster that real engagement at the community level with community leaders, with people who are affected. That's excellent. Thank you. Thank you, Simon. Dr. Kwamavi, in the African region, I'm sure that there's been a lot of efforts around community engagement, community involvement, and the task shifting using community health workers. Do you want to comment a little bit on some of your experiences?
Yeah, thank you very much. So speaking to the African context, I think I will mention 3, health system barrier. The first one will be the human resources, and I think all the colleagues has already raised that. We have shortage in, human resources. And as you mentioned, task shifting is one of the key approaches. But in terms of research in that area is how do we investigate the effectiveness of training, especially in the model of task shifting and task sharing, to build capacity at primary care level, and how that impacts access to care at that level. And then secondly, speaking to a health information system. And I think one of the barriers we have is a poor data collection management, but also the use of data for decision making, especially in diabetic care. And in our region, we are working currently in an initiative we call the D-Card initiative in 2 countries, where we are trying to use digital solution using simple smartphone or tablet to collect information at primary care level, to monitor individual level data on patients living with diabetes. And then lastly, I wanted also to mention the barrier linked to community engagement and awareness. In Africa, we have a low awareness and then a health-seeking behavior for diabetic screening and management in the region. So one of the areas to be considered in terms of research to see impact is a study around the impact of community-based education programs and also campaign to improve early detection, but also the impact of that approach on adherence to treatment and care. Thank you.
Thank you. Yes, community-based programs are critical. I want to switch a little bit now to gestational diabetes, because I think this is one of the real tough areas for all of us in all countries, I think, to improve the way diabetes and pregnancy, including gestational diabetes, is better diagnosed and managed, and ensuring positive health outcomes for mother and child. So I'd like to ask each one of the panel members, from your area of work and your perspective, what are some of those challenges, and what can we really do around gestational diabetes to improve its management? And I'll start again in order with Dr. Barrington.
Thank you. Big question. If I think of the project that we were running in Tajikistan and Kyrgyzstan, one of the important aspects was breaking down the barriers between the hospital and the antenatal care. Because there were the specialists in the hospital, and then there were the people in the primary health care, and they were very separate. And yet the pregnant woman is moving between the two. And to try and assess what was going on, we formed a multidisciplinary team who examined health records in the hospital and health records in the antenatal care, in the primary healthcare system, with a set of indicators so that we could try and assess how good was the quality of care for diabetes and hypertension disorders in pregnancy. And that in itself was useful because we involved specialists, family doctors, family nurses, academics. They began to see how bad were the records and how bad was the communication between the two sides. So when they were looking for the outcome of a hospital visit, they realized there was no letter from the hospital that had been sent. When they were looking for the result of the test, they discovered there was no test result there. When they looked at a woman being sent to hospital, etc., they discovered that no information had been sent with the woman. And so that was just the beginning of an exercise, which we then went on carrying this group with us to try and improve the care and also try and improve the interface of care. But something simple where we were taking both parts of the care, bringing them together and involving them in that first research exercise went beyond just the data in terms of breaking down barriers and engagement.
A really good point. It's sometimes the simple things, right? Bringing the care providers together and understanding each other's perspectives and finding the solution. Thank you, Jill. Dr. Herrera?
Gracias. En Perú,
In Peru, the way our healthcare system is organized, well, even though we are a middle-income country, our healthcare system is organized mainly to address the healthcare issues of a low-income country. In other words, we're better equipped to deal with infectious diseases and then to deal with problems that have to do with maternal or perinatal care. So we do need to take better care of pregnant women, but I would say that we are doing a better job at taking care of pregnant women also during labor and delivery. But we face the same problem we have with other communicable diseases, and it's that we don't necessarily have ways to screen pregnant women for diseases like diabetes. So we do follow pregnant women, we do track them, but we don't have screening methods or protocols. So we're trying to change that, and it's one of the aspects we are addressing. We're trying to improve the way we can do early detection, and we are using procedures that are not geared to gestational diabetes to familiarize our staff with how to diagnose diabetes in general. Thank you.
The main problem is that the medical doctors don't understand the issue. They are not familiar with the problem. They don't feel like they're ready to diagnose and to follow up the patients. That's the first thing. And then we have to evaluate the risk for developing type 2 diabetes. Many times these women are lost. We're not following what is happening to them because we could be working on diet, lifestyle to avoid type 2 diabetes. So I would say these are the two main gaps.
Gracias. Dr. Anderson?
Yes, thank you. So, looking at my notes, I think that one of the major things that we need to do is to improve the understanding of the condition itself. A lot of women do not understand the implications of having gestational diabetes, including the fact that within 2 years, they're 6 to 8 times more likely to get full-blown diabetes as well. So I think that that's part of the public health strategy to improve the awareness and knowledge and attitudes around the condition, and of course for family members to be involved in that process. And then at the primary care level, what we tend to find is that we did a little bit of a fact-finding sort of a community engagement exercise as we were trying to build research projects, and women went to their doctors quite late. So they may have discovered that they're pregnant at 6 weeks, 8 weeks, 12 weeks, but they don't get into the system. They don't access the healthcare system until much later in the pregnancy. And that means that the opportunities to screen early are lost. And of course, from that point of view, we were recommending universal screenings throughout, instead of waiting until the 3rd trimester, etc., to start screening as soon as possible, because that then engages the pregnant mom to understand that there are critical aspects long term, not just for her but for the unborn child in terms of the pregnancy, and then finally trying to sort of get some sort of digital passport that can be implemented across the region, which helps. Because not all of the healthcare facilities have access to electronic health records, etc. And so there's a problem of finding a record in a trailer or somewhere else. You know, the woman comes in, the record is just missing, and you have to start again from scratch. And therefore, record keeping and assessment is limited because of those factors. So I think that those are some of the things that we think might help. And also, of course, after the pregnancy, to continue to get screening, we do have a small pragmatic clinical trial that we're going to assess as well. Assess this just to see if in the year after pregnancy, we're likely to change the mindset or the knowledge, beliefs, and attitudes for moms in terms of their health and the fact that they may have it, and also then transfer that onto other conditions in pregnancy, like hypertension in pregnancy, which may occur at the same time. Yeah. Thank you.
Excellent work for education, community engagement, screening early, service delivery strengthening, but also for research. Thank you. Dr. Kwamavi, gestational diabetes and the work you're doing in the Africa region.
Thank you for the question. So I think in Afro here, the first step is a collaboration between our different units, NCDs and also maternal health, because one of the key actions is to increase awareness and education, especially at community level, by raising the knowledge about gestational diabetes, the risk, the prevention, but also the management. And also integrating the universal screening, as mentioned by the colleagues, is important, ensuring affordable care for women when it comes to having access to essential medication and diagnostic when it comes to gestational diabetes. But also importantly, we need to train healthcare workers, especially at primary care level, to understand what is gestational diabetes, but also how they can manage effectively and refer at the due time to upper level when it's necessary. Thank you.
Thank you. Yeah, so it's loud and clear. I think we've heard it from all the panelists. Training primary care providers in screening, diagnosis, management of gestational diabetes, but also educating women themselves and their families. So thank you. So, we've touched a little bit on the topic of access to essential medicines, especially insulin, and we saw some of those stark differences in analog versus human insulin prices. And we know that there's strong market forces in all countries to push towards analog insulin. And we also saw some gaps in access to blood glucose measuring devices. And at PAHO, we have a pool procurement mechanism that allows all countries in the Americas region to purchase these essential medicines and technologies for diabetes at one unique price, regardless of purchase size. Yet we see many countries still not taking advantage of this excellent resource. So I'd like us to talk a little bit about what we think are some of the barriers to improving access to the essential diabetes medicines and technologies, and how can we, as researchers or government decision makers or international organizations or funders, kind of help influence that we have greater access and that people with diabetes don't have to go without medicine or without glucose measuring devices. So let's go in reverse order this time. And Dr. Kwame, maybe I'll ask you to start if you can reflect on that for the Africa region and the work that you're doing there on this issue.
Thank you very much. And firstly, congratulations to PAHO to have this pool procurement, system. I think it's something we are trying to set up in Afro. Currently, we are doing a regional situation analysis, to really understand what are the barriers linked to access to medicine, but also pricing, especially for diabetic and cardiometabolic condition, medicine and technology. So in terms of barrier, I can mention the cost, diversity in cost, high cost of essential medicine, especially insulin and some of the technologies such as like the glucose monitor, which remain unaffordable, especially when people have to pay out of pocket. We have also the weakness of the supply chain system, resulting, frequently in a stock out of most of those essential medications in some of the countries. And lack of local production is also one of the challenging issues. Currently, there is an ongoing effort between African CDC and WHO Afro to see how we can strengthen more that local production, to avoid the dependence and importation of those medications, especially insulin, which is key when we are talking about type 1 diabetes, for example. We have also the inadequate, of financing, a lack of health insurance for everybody, especially only government workers in most of the countries have a certain level of health insurance. So when you go to low rural level and primary care level, access to medicine is challenging because people have to pay out of pocket. So those are some of the barriers in terms of accessing diabetic medicine and technology. I can also mention the issue of diversity in terms of equipment. When you see the glucose monitor, for example, in our region, you have some facility when you can visit, they have the equipment, but to get the Lancet, it's not easy because maybe the supplier is different from the one pushed by the government. So those are some of the challenges in terms of the weakness of the supply chain issues in our region. Yeah, thank you.
Thank you. Dr. Anderson in the Caribbean.
Yeah, so I know the situation in Barbados. There is central drug service that acquires medications on behalf of the whole population, but we're still subject to some of the issues that were described, including supply chain. I mean, to get things into the Caribbean, the number of flights and so on coming in, it may impact on the availability. So even if there's use of the mechanisms to get medications, the availability will be a problem from time to time. And that also comes down to some of the problems with screening and monitoring equipment and handheld monitors, etc. These will technically the patients need to pay for that themselves. So even though I know in some instances, if you purchase the device, you get the strips and so on for free, it's still a cost to purchase the device. So there's some affordability across the board in terms of screening. But I think that in terms of medication, Jamaica also has this national mechanism to get medications to individuals, particularly those who are at most need. And so it still just boils down to availability in that situation. Yeah. Thanks.
Em Brasília, a gente tem uma situação bastante favorável.
Now we have a very favorable situation as far as the provision of insulin, oral insulin. Perhaps we could optimize medical education to help people understand the proper way to take this medicine. And studies on cost effectiveness need to be done because we don't have any local studies that have been done on cost effectiveness. The ones we have access to are international. They don't really reflect our reality. And that would have a bearing on the availability and provision of these medications.
In our country, we have a system, and that is we have verification of availability of medicine at the national level. If you go to our webpage, you can see that all the hypertensives, all of the anti-diabetics are either overstocked or in stock. But for some areas in health, there are no medicines. So there is a problem in terms of what exists at the central level and what exists in a given health facility. So that's a major problem. Also, that happens because this is not a central level responsibility. It's a regional responsibility. Our country is not a federal system like Brazil is, but there is an economic dependency in health. Or he corrects himself. In the regions, there's a problem with identifying the healthcare facilities that are lacking medicine. And this is a problem having to do not only with medicine, but with all indicators for non-communicables, because we have a registry system. We do not have a unified registry system. That would be the case for pharmacies and for supplies. So it's not only, or in the regions, they really don't know what facility is lacking a medicine. So these are very important aspects. Another aspect that has to do with the registry, and this is something that happens in other countries too, is that programming medicines is done 1 year in advance. So you have to look at the history of the patients receiving care. So I'm planning for next year, and I'm basing my decision on the population that I served last year, plus 10%. But if I do a good diagnosis, I underestimate the number of patients, and so I'm not going to be able to economically program the amount of medicine I need. So there are two problems there. What we are trying to do right now, and this is something that I had discussed with Dr. Kahneman, is we're trying to close the gap in terms of the number of patients with diabetes, but that don't know they have it. That's going to mean that programming is going to have to increase, but it has to do that 1 year in advance. So I'm going to see a significant number of patients, but since I planned last year the resources I need, I'm not going to have the medicine for that new group. So that's a major challenge that we have right now, and it's an important one. We're interested in this challenge because what we're doing is reducing the number of patients. Right now, we only have 4 out of every 10 diabetic patients that are well identified. So we're trying to close that gap, but we know that if we do that, we will have a lot of medicine we're not going to be able to cover. So these are barriers we're trying to overcome, but at least we have been able to identify the barriers and we're trying to overcome them.
Thank you. Maybe I'll tell you about an exercise we've been doing in the European region that's relevant. We've been using the global diabetes targets to kind of test assumptions with ministries of health. So we're trying to work with a group of countries to help them measure the global diabetes targets in their country to see how well are they actually doing and how does it compare to how they thought they were doing. So we're in Europe, so everyone thinks we're doing really well. And of course, we can reach 80%, 80%, 80%, etc. And so we've asked each Ministry of Health to assign a diabetes expert and a surveillance expert to work with us. And of course, the reality is very different to what they were expecting. When we get to target 5, which is around 100% of people with type 1 diabetes should have access to insulin and devices, they all said, yes, of course, it will be 100%. It's in our health benefit package done. So we've been actually working with them to push this further. And the big issue has been around devices in particular, and also the insulin may even include a co-payment. So in the end, we could only find that 5 of the 13 countries were 100% available, and the others had some kind of co-payment that was attached to it. And so we couldn't be sure that it was all being reached. We also then tried to go a stage further to actually look at their prescription data to see if we can see, are there any groups that are left out or potentially are not being reached? Is it really equitable across the country? And we're at the kind of in the process of going further into that. So I think that just to say that I'm a big fan of the targets, and also using them with policymakers to try and self-assess, and particularly around this one of target 5 and access to insulin and devices, it sparked some conversations and tested some assumptions.
That's excellent. I think that's a good action point that we can come out of this meeting, is maybe do something similar with countries in our region to really use those diabetes targets and assess how we're progressing towards them. So I thank all of our panelists, because we've run out of time. This has been a very dynamic conversation, very rich with experiences from across the globe, Europe, Africa, Caribbean, Brazil, and Peru. And I just want to thank you all for sharing your insights with us. And that ends our session for this morning. So thank you. Thank you. And thank you to everybody who's connected online. We're going to take a break for an hour for lunch and reconnect online at 2 o'clock for further discussions. And thank you to our translators and technicians and administrative support staff for putting together the webinar portion of our meeting. So thank you, everyone. Thank you. And we'll see you at 2 o'clock.
Thank you.
Oh, we wanted to take a picture, right? Yeah. So Arancha? Oh, Mechi, where are we going to take the picture? Okay, so we'll just move outside and take our photo, and then we'll move for lunch and we'll show you where lunch is. Yeah, thank you. Thanks, everyone.